Cohort. What is quarantine actually? I already told. Coherent means to pay your respect, your homage to the person. So, skill. In my last class, I have discussed with you about the definitions of communication and its types and its features. There were 5 types of mainly communication: that verbal, non-verbal, written, and that formal and informal. I hope you have already gone through the whole video and you have cleared your queries. Now the next part today we are going to start, that is the 7 C's of communication. First of all, let me clear you what is 7 C's of communication. Actually, C, from that letter only it is clear that communication, you all know that this is a process, right? So to continue the process, we have to take the help of some ways, or you may say the help of some method. And in actually there are 7 processes that can lead you to a perfect communication, to a complete communication, to an effective communication. Okay, so these are the 7 ways which you can follow to complete an unique communication, where being a sender you are always getting the feedback from the receiver in an instant way. Okay, in an instant way. That is the main thing we all need, the feedback. So let us see what are the 7 C's of communication. Okay, and why the name is given in such way 7 C's, because the all 7 ways that I already told you about, that 7 ways all are continued in the word and the spelling that all started with C, particularly C the letter begins with. That's why these all are called 7 C's of communication. Okay, these are the ways. C. Seven C's of communication. Whenever we are going to run a machine, there are some process. Suppose computer is a machine, so there is a process to start up the computer. There is a process to turn up the computer also. In any machine, anywhere, where are you going, which one you are doing, whatever you are thinking about, all that has a process, all that has a way. And communication is simply a process, so that should be run with the help of ways. And here 7 C's of communication, the C, 7 C word starting with the letter C, these words will be helpful to you to run a communication in a gentle way. Okay, so let us see what are the 7 words. Number 1, clear. Number 2, correct. Number 3, complete. Number 4, concrete. Number 5, coherent. Number 6, concise. Number 7, courtesy. Right? Now let us discuss with this. Number 1, this is clear. clear. Clear, from this very word only it is clear to you that to be clear. To be clear means whatever you are representing, whatever you are informing, whatever you are trying to inform, that all must be clear. Your message, your information should be clear to the sender, to the receiver. Then only it will be always easy for the receiver to give you the feedback. So, in one word, the total sentence, or maybe it is a word also, that should be meaningful, clear in the sense meaningful, so that no other cross questions will be there a little while after, or maybe instantly you will get the feedback, right? Second, that is correct. Correct in the sense you have to be correct with your information. Suppose you are informing something, that time you are only incomplete with your information. You are only unable to be confirmed whether it is correct or not. So that time how you are informing the receiver, right? So whenever you are informing the receiver, you should be correct with you. So better you first collect the correct information, better you gather the correct idea about what you are going to represent, then you just inform the receiver that one. That time it will be helpful for the receiver also, and he will give you the positive feedback. Okay. Otherwise, if you provide any wrong information, any incorrect one, that time you will get the negative feedback, and in future maybe the listener won't listen to you again. Right? Thirdly is complete. What is complete? Complete, we know, complete means totally, whole, in a whole. So, which one we are representing? Whatever we are informing, the total information should be there. No little one or no skipping going to the end like this, it won't be. Whatever you are going to tell, whatever you are telling, whatever you are reporting, whatever you are informing, that should be complete. Like, I will go to the school in the morning. So this is a complete one. If you say, I will go. I will go is also a sentence. But question is there, where are you going? When are you going? Like this. So better you should give the complete one. Like, I will go to the school in the morning. Or maybe I will go to the school by bus. Or maybe I will go to the school with my friends, like this, anything. But whatever, that should be in a complete way, right? Fourth, concrete. You may think about this term is like building related to civil engineering. It is related to, right? Okay. So concrete, the word is actually in that sense if you are applying for, but in the building sense if you are applying for concrete building, that means the building is made up of brick, cement, stone, and it is congested, it is very stiff, it is very strong, and no air or water is there, it is hard, right? So whenever you are producing your information in a concrete way, that should also be in a solid way. No fake things, no false information you can provide. Then only it will be concrete. You will be reliable to your listeners. They will believe in you. They will trust on you. You will be a truly speaker. You will be a catchy speaker. Others are waiting to listen to you. They will depend on your words. How? If you will be concrete. Concrete in the sense, avoid any kinds of false information. Avoid any kinds of repetition. Avoid any kinds of incomplete one. Right? Then, fifth is coherent. What is coherent? Coherent in the sense, it should be relevant to your last one. relevant to your speaking. Whatever you are speaking about, it should be relevant to that. It should be topical. Right? Suppose now I am taking your class in this communication 7C, and now I am discussing about one cooking recipe, or maybe now I am giving you some health tips, or maybe some general topics I am just discussing about. So these are irrelevant regarding this class, right? If by chance some things may come, that time I may continue, but that should be in a little way. That should not be for the whole, that the whole class is going in for giving health tips. The class is not on giving health tips, right? The class is not on any cooking show. So how can I share any recipe with you? Because it is an irrelevant topic. You should have to stop that right now. Because, so like this, coherent. Whenever you are a speaker with your listeners, with your audience, with your receiver, you should be relevant about which topic you are going to speak, about what you are discussing. You should fix that. You should prepare. You may prepare regarding that or may not, but you never share any irrelevant information regarding that topic. Okay? Whenever you are going to share anything, that should be coherent to that topic we are discussing about. Right? Sixth, concise. What is concise? Concise in the sense, be brief. Whatever I am discussing, that should be in a brief way, so that interest of the receiver may not go. Otherwise, if you are giving your lectures for suppose 2 hours, your topic is just little, but for 2 hours you are just speaking, nobody will listen to it. So what you have to do? You have to just take some catchy points. You have to take some brief ideas, and you have to try to deliver your topic in such a way so that the interest of the receivers will be there. If there will not be any interest, that time no need to speak up that much, because you are already giving a vast lecture. Vast lecture you may have to give, but there also should be a concise way, right? So that audience interest must be there. I am speaking, but for whom? For the audience. If they are not listening, if they are not replying, so for whom I am speaking here? No need, right? So whenever you will give through, whenever you will go through any communication process, you should have to be concise. Keep in mind. Last, that is courtesy. Courtesy. This word simply show your personality. As a speaker, you are very good, but as a person, how you are? From your this way, you will show that I am a gentle person, or maybe I am a rude person, or maybe I am a funny person. Right there? So whenever you will speak to anyone, as a speaker, how much good you may be, but if opposite you, that is your listener, that is your receiver, so you should pay homage to that person. Okay? Maybe he is not literate like you, maybe his status is not that much high like you, maybe he is not smart like you, maybe he is not a fluent speaker like you, whoever he may be, but as a means right that time he is or she is or they are your listener, they are your audience. So you have to give your homage to that person. You should pay respect to that person. Okay? Whenever we will give respect to others, we will get back that respect in return. That you also know, right? So no need to disrespect anyone unnecessarily. If sometimes it's necessary very much, that time don't disrespect others, but you protest for your self-respect. That I can say. You protest for your self-respect, but you don't have the right to disrespect anyone without any reason, right? And during your speaking, you must pay that respect to others, so that in feedback you will also get back that respect. And how you will show that respect? No need to show your hands fold to them, or no need to touch their feet. You just use some polite words in your communication. Okay? What are the polite words? Polite words are like sorry At the time of need, you should say sorry. Thank you. This is also at the time of need, you should say welcome. At the time of need, you will use this. And please. Please, obviously, whenever it will be needed, we should use this. So these are the 4 polite words. These are the polite words. These we should use during our communication, so that our communication process will be catchy, will be gentle, will be full of courtesy to others. Okay? Now, I am just explaining this fact a little. Let me erase the board. Just one line or 2 lines I will show you to explain it in a fast way. First point was clear. You all know. I have already speak up about this. So let me write. As a speaker, we should be clear with our words. As a speaker, we should be clear with our words to the receiver, so that it will be meaningful for the receiver. Okay? And there will be an instant feedback in return. Okay? So whenever we will speak, we should keep in mind that the receiver must understand what we are speaking. So we have to speak in a clear way, so that the receiver won't have any question in their mind, and they will instantly, soon after realizing what we are speaking, soon they will give the feedback. Right? So this is number 1. Now number 2. Correct means true or right. Like this, thumbs up. So whenever we will deliver any message to the receiver, it should be correct. No false information we should give. So like this, being a speaker, we should deliver correct information to the receiver without any false one. Being a speaker, we should deliver correct information to the receiver without any false one. No false things we can deliver there. Only correct things. Third, complete, complete in the sense you should provide complete information to the receiver. So provide total information regarding your discussion. Provide total information regarding your discussion so that no cross question may appear there. From whom it will appear? Obviously from your audience, from your receiver. From receiver. Okay. So these are the three that we have already done. Now rest 4. Let us discuss. First let us revise this. One more I am telling. Clear, correct, complete. Number 4. Number 4, that is concrete in the sense, whenever I told you already, this whenever we are taking it in the sense of building construction, so concrete means hard, solid, and this also simply applied for communication process, that you should be strong means hard. Whatever you are speaking, no false or fake information is there. Totally it is solid one. Whenever we are making any notes, how we are making? We are first reading, we are first going through the text, we are first going through the lectures of the teachers, then we are just taking the main points and we are explaining it. So no other false informations are there. Everything is just gist way. Concrete, that is solid. So as a speaker,
one of the important diagnostic tests that was used earlier was heme agglutination. This heme agglutination is caused by these receptors. Okay. Now, mixoviridity is classified into 2 types. One is the orthomixoviridity and the paramixoviridity. If you look at the differences between the ortho and the paramixoviridity, you will see that first the shape of orthomixoviridity are spherical, whereas in case of paramixo they are pleomorphic. They are slightly larger as compared to the ortho. Another important is, see, although both of them have negative sense single stranded RNA, in case of paramixoviridity they are unsegmented, whereas it is segmented in orthomixoviridity and they have 8 pieces, whereas in paramixoviridity it is only 1 part. Okay. Important differentiation, another type is, see these 2 points, the genetic recombination and antigenic variation. These 2 phenomena are seen with orthomixoviridity but not associated with paramixoviridity. Now let us see the main organisms over here. In orthomixoviridity, the main important organism is influenza virus. I think you have heard about influenza. Many people get flu-like illness. So the flu is actually denotes influenza. Whereas in paramixoviridity, you can see it is comprised of parainfluenza virus, mumps, measles, respiratory syncytial virus, and metapneumoviruses. Okay. Let us consider them one by one. First, let us look into orthomyxoviridae. So, as I have already stated, they are spherical in shape. They have 8 segmented single-stranded negative sense RNA, and they have some features like this. It is Na or neuraminidase, and the other one is the hemagglutinin. The neuraminidase is the spherical shaped receptor, and the neuraminidase is the triangular shaped receptor. Now, these viruses also have another thing that is called the envelope. This envelope is derived from the host cell membrane. This envelope is very important. Why? Because if the virus loses its envelope, it cannot infect human cell. Okay. Now, envelope is made up of lipids. So, any chemical reagent which is capable of dissolving lipids can make the virus non-infective. Okay. So, this is the basis of using of hand sanitizers. Why? Because hand sanitizers have alcohol in them. Lipids gets dissolved in alcohol. Hence, the virus gets neutralized. Why this is important? Because influenza can cause outbreak, epidemics and pandemics. Recently, I think you have all are acquainted with the COVID pandemic. And in the pandemic, a very important part is prevention of spread of infection. An important part in case of influenza virus of prevention would include, that is, using of hand sanitizer. Now, so this hemagglutinin, as the name suggests, they bind with the RBCs and cause agglutination. Hence, they are called as hemagglutinin. And they bind with the receptor of the respiratory epithelial cells. Okay. So, this is the first step of binding, is binding to the respiratory epithelial cell membrane. Next comes the neuraminidase. These, what is the function? They have sialic acid receptors on RBCs. So, this binds with those receptors and degrade the receptors. I'll come to it. So, I'll just remember this sialic acid receptor is very important, because particular type of virus infecting particular species, maybe humans, maybe animals, maybe even birds, that depend on these kind of receptors. Okay, I'll explain later on. So what happens is, this facilitates the virus entry, then the virus replicates inside the cell, and with the help of this receptor, they cause the cell lysis and the virions escape into the environment. Okay. So these are the two main important receptors. Another important feature of influenza virus is the antigenic subtype. Now, the ribonucleoprotein is the main antigen over here, and there are 4 types, A, B, C, D. Furthermore, as I have already said, the neuraminidase and the hemagglutinin, they are also different. Based on that, there are 18 hemagglutinin types and 11 neuraminidase. This denotes the antigenic subtype. Now, influenza B and C viruses are also there, but they do not have antigenic subtype. And influenza D does not cause human infection. Okay. Now, why this is important? Because the various types of influenza virus are classified based on the antigenic structure. Sometime previously, there was an outbreak of avian influenza, especially in China, and later on spread out throughout the world. Those had different subtype, antigenic subtype, than common infections that are caused by human influenza. So, how this antigen is classified, or the nomenclature, just look at this. First is the type of the influenza, whether it's influenza A, B or C. Then comes the host. The host is important only if it is a non-human host. If it is a human host, then we do not write the host, because we are actually dealing with organisms which are pathogenic to human beings. So if any virus which are capable of, which are predominantly pathogenic to others, animals or birds which are capable of human infection, they are denoted with the host. Next is the geographic origin. Now please remember geographic origin. Origin means it is the first geographical region where the virus was first isolated. Next comes the strain number, then year of isolation, and then comes the antigenic subtype. As an example, you can see a human strain like influenza A. Because it's a human strain, no need to mention of human. Hong Kong, first isolated in Hong Kong. Then comes the year of isolation, the strain number, then year of isolation, and finally the antigenic subtype, that is H3N2. Similarly, if it is a non-human strain, we classify it like this: influenza/swine. Then swine means it can infect pigs. Then Iowa is the place where it was first isolated. 15 strain in the year 1930, and the antigenic subtype is denoted as H1N1. Okay, so this is how influenza virus is denoted. Now another important, now if we have understood that there are many types of antigen, a particular phenomenon is seen in influenza virus. It is called as antigenic shift and antigenic drift. I'll explain, just listen. What happens is, sometimes because of genetic reassortment, because they are RNA viruses, they are more prone to changes, and these changes will lead to change in the antigenic structure. Most important antigenic structure that is changed are the H and the N. That will denote which type of animals or mammals or birds this particular virus can infect. Sometimes the shift is a gradual shift, slow progressive shift. That is called as antigenic shift. And sometimes there are sudden drastical changes. That is called as antigenic drift. Now just look at this picture. What happens in antigenic drift is there is a sudden mutation. This leads to sudden change of the antigenic structure. Whereas in antigenic shift, what happens? Look at this picture. An avian influenza changes its antigenic structure, then infects the pigs. Again, there is a change occurring from the pigs, and then it jumps to the human beings. So this is a slow but gradual process. This is called as antigenic shift. Have you understood? Now, antigenic drift occurs because of minor changes and point mutations seen in both influenza A and B. What is the outcome of antigenic drift? Because it is slow and gradual changes, sometimes outbreaks and minor epidemics may occur. And these changes occur almost every 2 to 3 years. And it's a continuous process. Whereas antigenic shift is a major drastic change because of the genetic reassortment. It occurs only in influenza A virus. Okay. Not in influenza B. And it occurs by a period of 10 to 20 years. And whenever it occurs, it can lead to large outbreaks, epidemics, and even pandemics. Now let us come to the pathogenesis. The pathogenesis is very simple. Like all other respiratory viruses, they enter into the upper respiratory tract. They bind with the epithelial cells of the upper respiratory tract, then enters into the lower respiratory tract, where they bind again with the receptors over there, and then cause damage to type 2 and type 1 pneumocytes. Okay. Now what will happen? It will form what is known as syncytial formation, that is multiple cells will agglomerate to form a large cell. Okay, this is called syncytial formation. It have inclusion bodies and will lead to apoptosis by lysis. And because of the cell damage, the primary damage that occurs is impairment of oxygen transfer. Okay, hence you will see most of the patients who have severe influenza virus infections will ultimately end up having ARDS or acute respiratory distress syndrome. Now, so what is the transmission? The transmission is mainly by aerosol. If it is transmitted by aerosol, then what would be the best way of prevention? Which type of mask? Exactly. This is the reason why, remember that if a patient is having infection with influenza virus, it is very important to isolate the patient, especially with airborne isolation. Okay. Droplet infection can also occur. Obviously, if there is something can cause aerosol infection, droplet infection can also occur. Now, what happens is that the hemagglutinin attaches to the sialic acid receptor, which is present on the ciliated columnar epithelium. Now, ciliated columnar epithelium is present in lungs. Then the virus multiplies locally and then spreads locally. What happens is cellular destruction, edema, and mononuclear cells will come. Now, I had already told you that the neuraminidase receptors have sialase enzyme which binds with the sialic acid receptor. Look at over here. There are two types of sialic acid receptors: alpha 2,6 sialic and 2,3. The 2,6 sialic acid receptors are present in human upper respiratory tract, including trachea and tracheobronchial cells. Hence, all the influenza viruses capable of human infection, they have receptors which they can bind with the sialic acid receptor of alpha 2,6. Alpha 2,3 receptors are present in birds in the intestinal epithelium. And also look over here, it is present in humans in very small number in trachea, bronchi and alveolar cells. Okay, this is the reason why some of the avian influenza viruses can infect human beings. Now, I had already told you pigs play a very important role. Why? Look over here. The avian influenza virus is present in the birds. Now, pigs have both alpha 2,3 and 2,6 receptors in the respiratory epithelium. Okay. Suppose avian virus has this receptor, attachment to this receptor. They gain access into the pigs with genetic mutations, slow but gradual. They acquire affinity to alpha 2,6 receptor. Now, when they have both alpha 2,6 and alpha 2,3 receptor, which they have acquired from the pigs, now they can easily infect human beings. Okay. This is one of the phenomenon how this virus can jump species barrier. Species barrier means it can jump from one type of animals to other. Now, if we look at all the orthomyxoviruses, you will find that various types, they can infect various types of animals, including humans. Okay. Why this is important? Because we had already seen an avian influenza virus outbreaks and epidemics. What I am trying to implicate is any virus, orthomyxoviridae from any affecting any mammals or animals can jump the species barrier and cause human infection. Okay. Now let us look at the human immune response. what is the immune response to this virus. So, I had already said that hemagglutinin and neuraminidase, these are the two antigens which are mainly important for viral entry into the cell. So, if the human body produces antibody against these two antigens, that antigen would be protective. That means the virus can enter into the body but cannot cause the disease. Understood? Obviously, because the infection occurs in the respiratory epithelium, local immunity is more important than humoral immunity. Understood? Fine. Another concept in influenza virus is known as original antigenic scene. Now you have understood that there are many antigens of influenza virus, and because of different types of antigen, and particular human body being can get infected with the influenza virus of different antigen repeatedly. Now, if you remember the immune response, when a particular human being is infected for the first time, what will happen? He or she will produce antibodies. Now, suppose this person is again infected with another influenza virus with a different antigenic structure. What will happen? It will start producing the antibody again. Because it has been exposed to the antigen previously, it will start producing the antibodies against the previous antigen in a higher quantity than against the newer antigen. This is called as the original antigenic scene. Simple. Now, coming to the clinical manifestations. I think you have all heard many a times you get a flu-like illness. You have skipped school in your childhood. You have taken rest for 2 to 3 days and then you have got better. So this is the most common presentation of influenza virus, like a flu-like illness, and sometimes it may be even asymptomatic. However, what will be the flu-like illness? The common symptoms like chills, mild headache, low-grade fever for a 2 to 3 days period, and then the patient recovers. Sometimes, if the infection is severe, it can cause pneumonia. However, please remember, in this case, the pneumonia is more commonly because of the secondary bacterial infection. A flu-like illness decreases the immune response of the human body, both local and systemic. And moreover, there is damage to the lower respiratory tract epithelium. Because the lower respiratory tract epithelium is damaged, it is more prone for infection with bacteria. Hence, secondary bacterial infection is very important in case of influenza infection. Other manifestation would be if a patient is already having any kind of respiratory disease, say COPD like chronic obstructive pulmonary disease or asthma, then this respiratory distress can get even severe. Sometimes it may even give up to fulminant infection causing ARDS and sepsis. Who are more at risk of this infection? This is important because you have to protect these patients. They include extremes of age, children and people more than 65 years of age, pregnancy, chronic diseases like chronic pulmonary disease, chronic lung disease, chronic renal disease, then people with low immunity, any sort of immune compromise, and children having high risk of developing croup, sinusitis, otitis media. These are all secondary bacterial infections that can occur in children. This is important because for prevention there is a vaccine. I will come to it later. Now, influenza virus have seasonal variation because of the antigenic changes. Every year the antigen changes and every year the people get more susceptible to infection. Now, An important type is avian influenza virus. There are many types. More importantly is the H1N1. They are lethal to chickens and turkeys but not to ducks. And they can spread from, this is the H5N1 is the currently circulating, other strains like H7N7, H9N2. The human infection is caused more commonly by the H1N1. This is responsible for the seasonal flu occurring predominantly in the December to January after the monsoons. Now, the government of India has reported H1N1 from many areas and have even categorized the infection into two types, the category A, B and C, depending on the clinical manifestation, and have given the advice for the treatment of the same. Similarly, the WHO or the World Health Organization has a global influenza surveillance and response system. The objective of this system is to identify the various circulating strains of the influenza virus, determine their antigenic structure. All this is done for the production of vaccines. Now, before coming to prevention, let us look at the laboratory diagnosis. So, for this case, the sample would be predominantly the respiratory tract sample, that would include nasopharyngeal swab or lavage, nasal aspirate and throat swab. The best diagnostic modality is by RT-PCR or reverse transcriptase polymerase chain reaction. Okay. Now, please remember, if you are suspecting influenza virus, the swab that is to be taken should be of semi-synthetic, that is Dacron or rayon, not cotton swab, because cotton has some chemicals which inhibit or destroys the influenza virus. So, if you take a swab, a cotton swab for diagnosis, most probably you will end up with a wrong diagnosis. Furthermore, I have already told you that this virus is in a lipid envelope. Lipid enveloped viruses are more liable to changes in temperature, pH and exposure to chemicals. So, you need to have a transport media for sending the swab from the patient to the laboratory. Okay. Just remember these two things. You need to have a transport media for sending the sample and the swab should be semi-synthetic. Now, earlier the diagnosis was made by inoculating the virus in embryonated eggs or in primary monkey kidney cell lines. I think in pathology you have learned a little bit about cell lines. Cell lines. Cell lines are commonly malignant cells which do not die or they can remain viable for a prolonged period of time. Okay. Now, this virus, what will happen when inoculated into cell line? They will cause damage to the cells, formation of syncytia and inclusion bodies. That's how we can diagnose them. But problem is, it is very tedious. You need a highly sophisticated laboratory for diagnosis. Other methods would include direct immunofluorescence test. In immunofluorescence test, antibody coated with fluorescent material is stained with the sample and observed under fluorescent microscope. But the best method is reverse transcripted PCR. More importantly is the real-time PCR. It can generate the results much quickly. I am just giving an outline of how the real-time PCR test is done. Okay, just try to understand. So, there are various genes we look for like influenza H1 and H3N2. These are the common infecting strain, and we have an internal control of the ribonucleoprotein. Okay. Now, if we look at this over here, only the ribonucleoprotein is amplified, others are not. Over here, the internal control is present, but the virus is not detected. Okay. Similarly, if we look at this, the internal control is there, only influenza B is seen. Over here, influenza A and H3N2, and over here, influenza A and H1N1. So this is how the diagnosis is made. I'm not going into the details. This is just the outline of real-time PCR. Other methods would include antibody detection. And antibody detection, I have already told you, hemagglutination is the best test for diagnosis, and other would be neutralization test. Whatever the test may be employed, the important point you should remember, until unless you get a fourfold rise in titer, serological diagnosis can be confirmed. So most of the time the serological diagnosis will come after the patient recovers. So it's a retrospective diagnosis. Now coming to treatment, just remember two things. Have you heard about Tamiflu? Tamiflu contains oseltamivir and zanamivir. These are given because they are neuraminidase receptor inhibitor. If it is a neuraminidase receptor inhibitor, what will happen? Cell damage will be prevented. Okay. Other include the matrix protein M2 inhibitor, amantadine and rimantadine. Please remember they only act on influenza A and influenza B. Okay. They should be given only in patients who are susceptible or have a chronic underlying disease in whom the disease can deteriorate very quickly. And it can also be used as a prophylactic measure when there is an outbreak or an epidemic is ongoing, especially for healthcare workers. Now, preventive measures, I have already told you, the transmission is by aerosol. So what would be the preventive measure? Standard precaution and airborne precaution. All the parameters including standard and airborne precaution should be followed. And the best method of prevention is by vaccines. There are two types of vaccines, injectable vaccines and live vaccines. Now the vaccines who are to be given, people who have extremes of age group, that is more than 6 months to 5 years and more than 50 years. Then people with low immunity, including pregnant women, and people who are coming in contact with patients having influenza infection. That is the healthcare workers. The global influenza surveillance and response system, I have already told you, monitors the various strains that are circulating, and they predict the probable antigenic strain which may infect in the next year. Based on that, they produce the vaccine. Okay. So it's a single dose of vaccine. Live attenuated vaccines are also present. Okay. Finally, chemoprophylaxis. Chemoprophylaxis should be given, I have already told you, in whom suppose people are infected with HIV, who are immune compromised and who are not vaccinated. During outbreaks, all elderly people, children and healthcare workers should be given chemoprophylaxis. Okay. So that was all about orthomyxovirus or influenza virus. Now let us see the paramyxovirus. The paramyxoviruses have got three types: morbilli, paramyxo and pneumo. Among them, the important viruses causing human disease are parainfluenza, mumps, respiratory syncytial virus and human metapneumovirus. Another group of viruses are the Nipah and Hendra virus. They are recently isolated virus and they can cause disease. I will come to it later. Now, paramyxovirus, in the differences, you have understood that they have a single stranded RNA, negative sense RNA, and it is not segmented. Now, first is the measles virus. You have heard about measles. Measles is a childhood illness. So what happens in measles? Any idea? You have read measles in PSM? No. So measles along with rubella, roseola, fifth disease and chicken pox, these 5 diseases are more commonly was seen in children. They were called as the 5 diseases of the children. Okay. And all of them produces rash. febrile illness with rash. Okay. Measles is highly contagious. Infection occurs mainly through the aerosol route, infects all epithelial cells, predominantly lungs and skin. Hence the manifestation of rash. Now, the virus enters into the respiratory tract. There is a local replication, and thereafter it causes viremia from lymphatic spread. After the viremia, the virus spreads into all tissues: conjunctiva, respiratory tract, urinary tract, small blood vessels, and because of the virus, there is local inflammation of the vessels. This causes the rash. Okay. After that, the measles outcome is, the most common outcome is complete resolution with lifetime immunity. Why? Because it causes cell damage. It not only produces humoral response resulting in production of antibody. This virus have no other antigenic strain. Hence, the single antigen, when the antibody response is there, the immunity is for lifetime. Okay. Problem is, sometimes after the resolution, it can cause what is known as subacute sclerosing panencephalitis. The infection goes on within the encephalon, either in acutely or chronically. If it causes acutely, we call it as post-infectious encephalitis, and if it is a chronic one, we call it as subacute. Subacute means the presentation is not quick or acute, but delayed, hence subacute. Sclerosing means it causes sclerosis of the encephalon or the brain parenchyma. This, if you can see, this is the child with a rash, and in the mouth there is a rash. This is called as oral rash. A significant important rash is known as the Koplik spot. Other than, if you see the distribution of rash in the face and the trunk, the incubation period is about 7 days, after which there are rash like Koplik spots, then rash, respiratory infection, viremia occurs, and then after about 14 to 20 days, the patient recovers. Now coming to diagnosis. Measles is commonly a clinical diagnosis. Okay. However, laboratory diagnosis can be done, although I have already said the cell culture techniques were previously done, but they are difficult. Hence, commonly respiratory secretion, urine, blood, they are sent, and for reverse transcriptive PCR, simple. When should you collect the sample? From prodromal stage up to 1 to 2 days after appearance of rash. After that, if you take the sample, most of the time it will come as a negative result. Okay. So when you should collect the sample? From prodrome, that is the febrile illness, 1 to 2 days after the appearance of rash. Other diagnostic method could be Giemsa stain of the multinucleated giant cell can be seen in upper respiratory tract sample and urinary sediment, and you can also detect IgM after the infection. Measles is now a vaccine preventable disease because of a presence of the vaccine. It's a live vaccine given along with mumps and rubella and sometimes with varicella. So either MMR or MMRV vaccine. Vaccination produces lifetime immunity. Because it's a live vaccine, it will produce a febrile illness post-vaccination, which is also. Now, parainfluenza virus. Why they are called parainfluenza? Because they produce signs and symptoms like that of influenza virus, but the intensity is much lower. Commonly produce a cold-like symptoms, may produce bronchiolitis or croup. However, it is generally not severe. Similar to influenza virus, the diagnosis is same, either serological diagnosis or RT-PCR. Important thing you should remember, unlike influenza virus, there are no vaccines for parainfluenza virus and there are no drugs approved for treatment. Now, for MMR vaccine, measles I have already told you, discussed. Next comes mumps. The mumps virus also comes under the paramyxoviridae family. Now, in mumps, what happens? The disease process is same. Patients acquire infection by respiratory route, causes viremia. But over here, it infects the glands, commonly the parotid glands, and in males, it can infect the testis and central nervous system. So what will happen is, it causes parotiditis, inflammation of the parotid gland, swelling of the face. And if this infection occurs after puberty, it can cause orchiditis, that is inflammation of the testis. And sometimes it may result in male infertility. Finally, because it can infect CNS, it can cause encephalitis. But in children, especially when the infection occurs below 5 years, most of the time mumps infection resolves without any kind of sequelae. So, it is acquired by respiratory tract, local replication occurs, after which viremia occurs, and from blood it spreads to parotid glands, various organs including pancreas, and in pancreas it can cause inflammation, loss of insulin producing cells or the beta cells, and cause juvenile diabetes. But significant is important over here, it can cause inflammation in testis and ovaries in post-pubertal children and sometimes cause infertility. So the incubation period is about 14 days, after which there is parotiditis, which is the common manifestation by which the diagnosis is made, and sometimes meningoencephalitis can be seen. Again, diagnosis is commonly done by clinical diagnosis. However, laboratory confirmation can be done by sample like saliva, urine, and oral secretions. If there is signs of meningitis or encephalitis, CSF can also be studied for the presence of this virus. Okay. Retrospective diagnosis can be done by serology, that is demonstration of IgM or a fourfold rising titer. Like other myxoviruses, growth can be seen in cell line culture, not commonly done. RT-PCR can also be done. Now, most important part of control is vaccine. The gerrylin strain is given as a vaccine along with measles. Okay. No antiviral is recommended for treatment of mumps. Coming to the next type of virus called as respiratory syncytial virus. Syncytial means it forms syncytium. Okay. This virus causes cold-like illness in adults. Important is, this virus can cause severe pulmonary infection in children, especially infants, and in extremely old age group people. It lacks both hemagglutinin and neuraminidase and can cause fatal ARDS. So what are the clinical manifestations of RSV? It can cause bronchiolitis, pneumonia, and in children it starts as rhinitis and pharyngitis. Later on may progress to full-blown pneumonia and ARDS. In older children and adults, it presents as common cold. Okay. In children, that is in infants, if there is infection of RSV, the treatment is mainly supportive, and if the infection is severe, ribavirin can be used and passive anti-RSV immunoglobulin can be used. No vaccine is approved till now. In human metapneumoviruses, these also cause cold-like symptoms and they are detected by RT-PCR. Most of the time, these infections are not diagnosed. Final group of paramyxovirus includes Nipah and Hendra virus. Nipah and Hendra virus both are recently isolated. If you go back and read about the various diseases in India, you will find out that recently in Kerala, there was an outbreak of Nipah virus infection. This infection commonly occurs, the reservoir is the fruit bat. When people come in contact with these bats, they get infected. They cause viremia and sometimes encephalitis, and many a times these are fatal and may manifest with seizure and coma. Treatment is generally supportive. There is no specific drug, no vaccine for this. Just be aware that these two viruses are commonly recently identified and they can cause outbreaks in future. The final virus that I am going to discuss today is the last part of the MMR vaccine, that is rubella. Now rubella along with measles is another childhood illness, febrile illness with rash. It is also called as the German measles. Why it was called German measles? Because the overall manifestation was less severe and for a less or a shorter duration as compared to measles. Hence it was called as German measles. The other name is the rubella. Now it begins with low-grade fever, malaise, lymphadenopathy with generalized erythematous rash. That is the common manifestation. So in children, rubella infection occurs. Most of the time resolution occurs and the humoral immunity is enough to produce lifelong immunity. Even in non-pregnant adults or women who are not pregnant and adults, it does not cause severe infection. What you should remember is, if a woman is not having any protection to rubella virus and she acquires the infection during her pregnancy, the outcome is very severe. If the infection occurs in the first 10 weeks of gestation, it causes massive damage to the fetus, which may result in miscarriage, fetal death, severe birth defects. This is called as congenital rubella syndrome. So it belongs to the rubevirus of the maternaviridae. It is a single-stranded positive sense RNA virus and it is sensitive to heat, UV ray and pH. So in that part it is not severe. Prevention can be easily done. So this is the incubation period between 14 to 20 days and then the disease manifests, which is the period of communicability. It enters through the nasopharynx and then viremia occurs and spread to all parts of the body, including respiratory tract. If it involves respiratory tract, the patient will present with cough, expectoration, etc. Skin resulting in rashes, lymph nodes. If the virus infects the lymph node, there will be lymphadenopathy commonly seen in the submandibular, postauricular and cervical lymphadenopathy. Mild arthalgia, arthritis may be present and it can infect placenta and cause fetal damage. The rash typically lasts for 3 days and then fades in the same directional pattern as it appears. Now come to the congenital defects. If the infection occurs prior to 10 weeks, there is a classical triad of cataract, congenital heart disease and sensory neural deafness. Okay. Cataract, heart disease and sensory neural deafness. This is called as the classical triad of congenital rubella syndrome. Other manifestations will include low birth weight, purpura, hemolytic anemia, splenomegaly, various types of ophthalmopathies, cardiac abnormality, microcephaly. These are the part of the congenital rubella syndrome. Now, in children and in non-pregnant adults, the diagnosis is very simple. Clinical diagnosis can be done. Laboratory confirmation can be done by demonstration of presence of rubella-specific IgM or a fourfold rise in titer. Finally, please pay attention to this one. Rubella-specific low avidity IgG. Now, in acute infection, you will see manifestation of IgM. When the infection goes into chronic phase, we get IgG. Okay. Sometimes the IgM can manifest for a more than 6 months period. Furthermore, IgG can be present in any woman. The avidity testing is very important for diagnosis. If, okay, listen. So if the patient is not pregnant, you don't need to worry about it. Okay. So in case of males, there is nothing to worry about. But in case of females of reproductive age group, you need to worry whether she is pregnant or not. If she is non-pregnant, you don't need to worry about it. But if she is pregnant, you need to demonstrate whether she is acutely infected or she was infected in the childhood or could be vaccinated. Now, if she is infected in childhood or is vaccinated in her childhood, what will happen? You will get IgG. Sometimes, even in acute infection, say after 3 to 4 weeks, IgG may be seen. Okay. So, suppose if a woman, say, who is 14 weeks in a gestation, and now you test her and you get IgG positive, can you say that she is not infected by rubella? We cannot say. For that, we need to do what is known as avidity testing. What is avidity? It is the affinity or the specificity of the binding of the antibody to the antigen. Okay. For IgG, what happens is, the more remote the infection has occurred in the body, the avidity increases. Suppose you are infected today. After 6 months, you will have IgG. The IgG will also be present after 1 year and say after 10 years. What will increase in that IgG is the specificity to bind to the antigen. This is called as avidity. So, in a pregnant woman, if IgG is positive but have low avidity, what does it mean? That the infection had occurred acutely, not a chronic. Sorry, not in remote, but the infection had occurred in a recent past. So, if the infection has occurred in the recent past, we have to estimate whether the infection has occurred within the gestational period or not. If the infection has occurred in the gestational period, there is a high chance of development of congenital rubella syndrome. Have you understood? So, if a pregnant woman is exposed to suspected rubella case, we need to test the rubella specific IgG antibody. If it is positive, then the patient is immune and she could be reassured. If the patient is have IgG positive and a high avidity, we can say that she has acquired in a childhood illness or vaccinated. In that case, nothing is to be done because the child is protected. If viremia may occur, the humoral antibody present in her blood will prevent the virus from spreading into the placenta and into the child. If it is negative, we need to test rubella specific IgM and IgG both. If the IgM is present, that means acute infection or recent infection, or sometimes the IgM may be absent and only IgG is present of low avidity. If that is the case, then we have to exclude 3 weeks period to exclude asymptomatic rubella infection. If it is a rubella infection, prenatally the diagnosis can be done by specific IgM of the fetal blood or detection of the rubella RNA in amniotic fluid or chorionic villus sampling using RT-PCR. This is the diagnosis antenatal, before the child is born. If the child is born, after that we can test for rubella specific IgM within the first 6 months. Remember that a child who is born have IgG from the mother, not IgM, because IgG crosses through the placenta, not IgM. So if the child is acutely infected in the gestational period, the child will manifest IgM in the blood, okay, not IgG. IgG can be used for testing after 6 months. Other recent methods include RT-PCR of the nasopharyngeal sample, urine, and even oral fluid. So what is the treatment? For children and non-pregnant adults, it is a symptomatic treatment is to be given. However, if the infection occurs before 14 weeks of gestation, termination of pregnancy has to be advised. If it is after 18 weeks, termination could be avoided, but the chances of congenital infection cannot be ruled out. This has to be explained to the patient. Okay. How to prevent this? The most important is congenital rubella syndrome. So how to prevent it? There is an established vaccine. And how does a person acquire the infection? From a rubella case. Most of the children are the infected case, and these children are commonly most of the children are handled by women. So a woman in the reproductive age group has a higher chance of acquiring infection from children. So to prevent the spread of infection, vaccination has to be done both in children and in women. Hence, all female child should be vaccinated with rubella. If any woman in the reproductive age group has no documented evidence of vaccination against rubella, has to be vaccinated. And post-vaccination, she has to be advised not to conceive after 4 to 6 weeks till the antibody levels. Another method is if a pregnant woman comes and says that she has come in contact with a patient of rubella, if she has come, then within 72 hours, specific anti-rubella immunoglobulin can be given to prevent the infection. Okay, this is the other method. So the diagnosis is commonly done mainly by RT-PCR, pharyngeal samples and urine cultures can be done. Now look at this picture. You see this child with multiple rash, infant born. This is called as blueberry syndrome. Blueberry muffin syndrome, because of the spots in the child. This is a congenital rubella syndrome. And over here you can see the child with cataract, nuclear cataract. This causes blindness. Other pictures include this is the rash and this is the virus. Now, finally, I have already told you there were 5 diseases or the 5 diseases of the childhood, all presenting with fever and rash. What are those diseases? These include measles, scarlet fever, rubella, erythema infection, rubella, and varicella. Diagnosis was previously done by the manifestation of the rash. In the measles, you can see the rash presents all over the body. In scarlet fever, predominantly in the face, armpits, and groin. In rubella, predominantly in the face and trunk. In roseola, in the trunk and face. And in varicella, in the centrifugal pattern. Varicella means chickenpox. Okay. So this was all about today's class. One of the important diagnostic tests that was used earlier was hemagglutination. This hemagglutination is caused by these receptors. Okay. Now, mixoviridity is classified into two types. One is the orthomixoviridity and the paramixoviridity. If you look at the differences between the ortho and the paramixoviridity, you will see that first the shape of orthomixoviridity are spherical, whereas in case of paramixo they are pleomorphic. They are slightly larger as compared to the ortho. Another important is, see, although both of them have negative sense single stranded RNA, in case of paramixoviridity they are unsegmented, whereas it is segmented in orthomixoviridity and they have 8 pieces, whereas in paramixoviridity it is only one part. Okay. Important differentiation, another type is, see, these 2 points, the genetic recombination and antigenic variation. These two phenomena are seen with orthomixoviridity but not associated with paramixoviridity. Now let us see the main organisms over here. In orthomixoviridity, the main important organism is influenza virus. I think you have heard about influenza. Many people get flu-like illness. So the flu is actually denotes influenza. Whereas in paramixoviridity, you can see it is comprised of parainfluenza virus, mumps, measles, respiratory syncytial virus, and metapneumoviruses. Okay. Let us consider them one by one. First, let us look into orthomixoviridity. So, as I have already stated, they are spherical in shape. They have 8 segmented single-stranded negative sense RNA, and they have some features like this. It is Na or neuraminidase, and the other one is the hemagglutinin. The neuraminidase is the spherical shaped receptor and the neuraminidase is the triangular shaped receptor. Now, these viruses also have another thing that is called the envelope. This envelope is derived from the host cell membrane. This envelope is very important. Why? Because if the virus loses its envelope, it cannot infect human cell. Okay. Now, envelope is made up of lipids. So, any chemical reagent which is capable of dissolving lipids can make the virus non-infected. Okay. So, this is the basis of using of hand sanitizers. Why? Because hand sanitizers have alcohol in them. Lipids gets dissolved in alcohol. Hence, the virus gets neutralized. Why this?
Today, we will discuss on topic regarding this reconstructive surgery. Under the reconstructive surgery, we will discuss on skin grafting. Skin grafting by name itself, the term means that it's replacement of the skin. Skin grafting is a technique in which a part of the skin is detached from its own blood supply and it is transferred as a free tissue to other distant place. Right? It is a technique in which a part of the skin will be removed from its own blood supply and it will get detached and it will be detached in the other part of the body where it is required, whether it is moved. Indications of skin grafting. In skin grafting, indications क्या हो सकता है? What are the indications? Where do we need skin grafting? Where do we need replacement of the skin? Like burn, wound, trauma, then any extensive skin loss due to infection की वजह से ज़्यादा skin loss हो गया, then
for any cosmetic surgery or reconstructive surgeries. These are some of the indications of skin grafting. They are, can you please repeat it again? Burn patient, for any burn, for trauma, for wound, loss of skin due to infection, or due to some cosmetic reason. Right? These are some of the indications of doing skin grafting. Classification. Now let's come to the classification of skin graft. Depending upon the origin of the donor, where the skin comes from. Right? Classification of skin grafting. So depending upon the origin, origin means from where the skin comes from where the donor comes from, right? The skin will be replaced from its own blood supply, right? In skin grafting, the skin will be removed from its own blood supply and it will get moved to the other place and it will get replaced with the other place where healing is required, right? So in skin grafting, depending on the origin of the donor, it is being divided into 4 types. The first type is autograft, otherwise known as autologous graft, right? First is autograft. So there are 4 types. First is autograft, second is allograft, that is heterologous, also known as heterologous graft, and third is xenograft, that is heterograft, and fourth is synthetic, that is synthetic skin substitute. This will act like a skin. This will function like a skin. It will be manufactured in the lab. The first is autograft. That is, the skin is often from the patient or itself. From itself, the skin will be taken from all body parts. Maybe from thigh, the skin is taken and it is replaced with the other part of our body. From all patient's body part will be taken, the donor. And second is allograft, that is also known as heterologous graft. That is often from the another person, maybe from you. I am taking the skin and it is replaced to me, right? That is from another person. That is known as allograft, right? And third is xenograft. That is also known as heterograft. Other term is also known as heterograft, and the skin is often from the other species. That is from the other species, not from man. Second one was from man to man, and third one, that is xenograft, is from other species like pig. Right? Example, maybe from the pig. It may be under any other species. But one of the example, the skin can be taken from the pig. And third is synthetic. I have also told you what is synthetic, that is manufactured. Synthetic means that will be manufactured in the laboratory. This will act like as the skin. Right? So these are the classifications of skin grafting. Skin graft, from where its origin. And also depending on the thickness of skin grafting, this is one of the classifications depending upon the origin. Next, depending upon the thickness of the skin, it is again divided into 3 3 That is AC means skin grafting. I am writing in short form. That is full thickness skin grafting. Then second is split thickness skin grafting, and last is composite. Right? Am I right? This last thing is the composite skin grafting. First, let's come to the full thickness skin grafting. In this process, both the epidermis and dermis of the skin, it will be taken, right? It consists of the entire dermis and the epidermis in the full thickness skin grafting. And next is the split thickness skin grafting. The skin will be taken in two layers, that is epidermis and some part of the dermis. What are the layers of the skin? Epidermis, dermis, hypodermis, subcutaneous muscles. So the first two layers, epidermis and dermis, is being taken in both the full thickness and split thickness skin grafting. But in full thickness skin grafting, both the epidermis and dermis will be taken. And second is split thickness, full part of the epidermis and some part of the dermis will be taken. But also depending upon the thickness of the skin which is taken in split thickness skin grafting, it is again divided into three depending upon the thickness. That is thin, medium and thick. Okay? And last is composite skin grafting. In composite skin grafting, combinations of skin and fat, cartilage, dermis and fat will be taken. Okay? In composite, it is taken in composite. Both the skin, fat, cartilage and dermis will be used in what? In composite skin grafting. So there are mainly three types according to the thickness. That is a technique. First one is full thickness skin grafting. Second is split thickness skin grafting. And last is composite skin grafting. Full thickness, epidermis, dermis. Then second one, that is split thickness, epidermis and some part of dermis. And last is composite skin grafting. Skin, fat, cartilage, dermis, it is used. Right? So how skin grafting is done? Graft application. So how do you prepare a skin for grafting? Have you seen any patients going to OT? Before going to OT, how do you, after once enter into the OT, what is the preparation done in skin? OT करने से पहले क्या करते हो? स्किन क्या करते हैं? क्लीन करते हैं। स्किन को प्रिपेयर करते हैं पहले कि कौन सा पार्ट ऑफ स्किन विल इंसाइज, जैसे इंसिजन होता है सर्जरी में, जहाँ पे इंसिजन होगा वहाँ पे पहले प्रिपरेशन ऑफ स्किन होता है। सेम लाइक स्किन ग्राफ्टिंग में भी जहाँ से लेंगे और जहाँ पे डालेंगे, both the part will be prepared for skin grafting, right? And this donor part क्या करोगे? It will be measured. पहले wound देखेंगे, wound का size देखेंगे. According to the size of the wound, depth of the wound, the doctors will decide how much thickness will be taken, right? How much thickness? It may be full thickness, split thickness, or maybe composite. skin grafting. Depending upon that, the measurement should be done first, and the area of the wound should be measured, right? According to that, the donor from the donor part it will be measured. कितना सेंटीमीटर काटना है, कितना शेप, कौन सी शेप पे काटना है, according to that it will be cut, right? Cutting करने का है knife से cut कर सकता है, otherwise it can be cut with the scalpel. Scalpel पता है ना? Blade. जो होती में यूज होता है blade, कैसा दिखता है blade?
ऐसा छोटा होता है।
इसका हैंडल होता है, काम करता है, पेंसिल की तरह करता है ब्लेड। ब्लेड ऐसे नहीं पकड़ते, ठीक है? ब्लेड ऐसे पेंसिल की तरह पकड़ते हैं, ठीक है? So it can be removed. The skin can be removed with the knife, or it has a special knife. ऐसा नहीं जो किचन में यूज होता है, ऐसा वाला knife नहीं है, ऐसा special knife. This is known as dermato. एनेस्थेशिया देने के बाद एनेस्थेशिया लोकल एनेस्थेशिया हो सकता है, रीजनल एनेस्थेशिया हो सकता है, अदरवाइज जनरल एनेस्थेशिया हो सकता है, depending on where the skin grafting is done. After anesthesia has been taken, the skin will be removed and it will placed the where the grafting is required. ठीक है? ग्राफ्टिंग करने के बाद डालने के बाद क्या करते हैं? साइड साइड स्टिच करते हैं, अदरवाइज stitching can be done or stapling can be done. Stitching or stapling, आपने stapler देखा होगा ओटी में, ओटी के बाद लास्ट स्किन कवर कैसे करते हैं? With the आजकल क्या करते हैं? स्टैपलर यूज होता है, स्टैपल से बंद कर सकता है साइड। यहाँ पे ग्राफ्टिंग हुआ है, फॉर एग्जांपल इस एरिया में ग्राफ्टिंग हुआ, साइड में सुचलिंग, अदरवाइज इट मे बी स्टेपल, ठीक है? स्टेपल और सुचलिंग, एंड द पार्ट वेयर इट इज रिमूव, जहाँ पे रिमूव किया है डोनर पार्ट जो है वो क्या करोगे? इफ इट इज फुल थिकनेस स्किन ग्राफ्टिंग या कंपोजिट ग्राफ्टिंग है, दैट मींस बहुत ज्यादा थिकनेस किया तो वो कवर करना चाहिए, शुड बी स्टिच कर सकता है, अदरवाइज इट इज स्प्लिट थिकनेस कम है तो क्या करोगे? वो ओपन ही छोड़ेगा, उसके ऊपर ड्रेसिंग लगाएगा, इधर इट कैन बी क्लोज और keep it open, ठीक है? After this grafting is done, the pressure bandage is applied. The bandage which is applied over the grafting part with little pressure. That is pressure bandaging should be done. Why pressure bandaging should be done? With firm bandaging. इतना प्रेशर भी नहीं कि इसका सर्कुलेशन बंद हो जाए, मगर there should be a firm bandaging should be done after the grafting is done. Why firm dressing or pressure dressing is required after the grafting? Without moving. And if the bandaging is, if the grafting is done on the legs में किया है, और it should be kept without moving for at least 7 days on bed. वो मतलब ढीला नहीं चाहिए, should be kept in the position, and the healings will start. Complications of skin grafting. Skin grafting complications. Skin grafting is the pain ज़्यादा, थोड़ा पेन सकता है, मगर if पेन बढ़ रहा है, जैसे हो सकता है, मगर if पेन बढ़ रहा है, जैसे उसको गैप हो गया था, अराउंड 2 or 3 days थोड़ा गैप हो गया था ड्रेसिंग, तो क्या हो जाता है? अंदर में स्मेलिंग हो सकता है, स्मेल आ सकता है, तो if smells comes, it is also a sign of infection. So the first complications of skin grafting is infections. Okay? And next is bleeding. Bleeding, it may be due to trauma or infection. Second complication is bleeding. It may be due to infection or due to trauma. And third complication is inadequate vascular supply to the wound bed. Vascular supply. It should be developed, right? The blood supply, it should be developed. Hematomas. And one is ग्राफ्स भी निकल रहा है, वो भी हो सकता है फ्रॉम वेट स्टेटस। और उस डिसेक्शन को कम करने के लिए क्या करता है, इम्यूनो सप्रेशंस देते हैं, उसका इम्यूनिटी को लॉस ऑफ ग्राफ्टेड स्किन और डिसेक्शन। सो दिस आर द कॉम्प्लिकेशंस। Today we will discuss on topic regarding this reconstructive surgery. Under the reconstructive surgery, we will discuss on skin grafting. Skin grafting by name itself, the term means that it's replacement of the skin. Skin grafting is a technique in which a part of the skin is detached from its own blood supply and it is transferred as a free tissue to other distant place. Right? It is a technique in which a part of the skin will be removed from its own blood supply, and it will get detached, and it will be detached in the other part of the body where it is required, whether it is wound. Indications of skin grafting. In skin grafting, indications क्या हो सकता है? What are the indications? Where do we need skin grafting? Where do we need replacement of the skin? Like burn, wound, trauma, then any extensive skin loss due to infection की वजह से ज़्यादा skin loss हो गया, then for any cosmetic surgery or reconstructive surgeries. These are some of the indications of skin grafting. They are, can you please repeat it again? Burn patient, for any burn, for trauma, for wound, loss of skin due to infection or due to some cosmetic reason. Right? These are some of the indications of doing skin grafting. Classification. Now let's come to the classification of skin graft. Depending upon the origin of the donor, where the skin comes from. Right? Classification of skin grafting. So depending upon the origin, origin means from where the skin comes from where the donor comes from, right? The skin will be detached from its own blood supply, right? In skin grafting, the skin will be removed from its own blood supply and it will get moved to the other place and it will get replaced with the other place where healing is required, right? So in skin grafting, depending on the origin of the donor, it is being divided into 4 types. The first type is autograft, otherwise known as autologous graft, right? First is autograft. So there are four types. First is autograft, second is allograft, that is heterologous, also known as heterologous graft, and third is xenograft, that is heterograft, and fourth is synthetic, that is synthetic skin substitute. This will act like a skin. This will function like a skin. It will be manufactured in the lab. The first is autograft. That is, the skin is often from the patient on itself. From itself. The patient's skin will be taken from all body parts. Maybe from thigh, the skin is taken and it is placed to the other part of our body. From all patient's body part will be taken, the donor. And second is allograft, that is also known as heterologous graft. That is often from the another person. Maybe from you, I am taking the skin and it is placed to me. Right? That is from another person. That is known as allograft. Right? And third is xenograft. That is also known as heterograft. Other term is also known as heterograft. And the skin is often from the other species. That is from the other species, not from man. Second one was from man to man, and third one, that is xenograft, is from other species like pig. Right? Example, maybe from the pig. It may be under any other species, but one of the example, the skin can be taken from the pig. And third is synthetic. I have also told you what is synthetic, that is manufactured. Synthetic means that will be manufactured in the laboratory, which will act like as the skin. Right? So these are the classifications of skin grafting. Skin graft, from where its origin. And also depending on the thickness of skin grafting, this is one of the classifications depending upon the origin. Next, depending upon the thickness of the skin, it is again divided into three. That is means skin grafting. I am writing in short form. That is full thickness skin grafting. Then second is split thickness skin grafting. And last is composite. Right? Am I right? This last thing is the composite skin grafting. First, let's come to the full thickness skin grafting. In this process, both the epidermis and dermis of the skin, it will be taken, right? It consists of the entire dermis and the epidermis in the full thickness skin grafting. And next is the split thickness skin grafting. The skin will be taken in two layers, that is epidermis and some part of the dermis. What are the layers of the skin? Epidermis, dermis, hypodermis, subcutaneous muscles. So the first two layers, epidermis and dermis, is being taken in both the full thickness and split thickness skin grafting. But in full thickness skin grafting, both the epidermis and dermis will be taken. And second is split thickness. Full part of the epidermis and some part of the dermis will be taken. But also depending upon the thickness of the skin which is taken in split thickness skin grafting, it is again divided into three depending upon the thickness. That is thin, medium and thick. Okay? And last is composite skin grafting. In composite skin grafting, combinations of skin and fat cartilage, dermis and fat will be taken. ठीक है? In composite, it is taken in composite. Both skin, fat, cartilage, and dermis will be used in what? In composite skin grafting. So there are mainly three types according to the thickness. That is a technique. First one is full thickness skin grafting. Second is limited thickness skin grafting, and last is composite skin grafting. Full thickness, limited dermis. Then second one, that is full thickness epidermis and some part of dermis, and last is composite skin grafting. Skin, fat, cartilage, dermis, it is used, right? So how skin grafting is done? Graft application. So how do you prepare a skin for grafting? Have you seen any patients going to OT? Before going to OT, how do you, after once enter into the OT, what is the preparation done in skin? OT करने से पहले क्या करते हो? स्किन क्या करते हैं? क्लीन करते हैं। स्किन को प्रिपेयर करते हैं पहले कि कौन सा पार्ट ऑफ स्किन विल इंसाइज। जैसे इंसिजन होता है सर्जरी में, जहाँ पे इंसिजन होगा वहाँ पे पहले प्रिपरेशन ऑफ स्किन होता है। सेम लाइक स्किन ग्राफ्टिंग में भी जहाँ से लेंगे और जहाँ पे डालेंगे, both the part will be prepared for skin grafting, right? And this donor part क्या करोगे? It will be measured. पहले wound देखेंगे, wound का size देखेंगे. According to the size of the wound, depth of the wound, the doctors will decide how much thickness will be taken, right? How much thickness? It will be full thickness, skin thickness, and composite skin grafting. Depending upon that, the measurement should be done first, and the area of the wound should be measured, right? According to that, the donor from the donor part it will be measured. कितना सेंटीमीटर काटना है, कितना शेप, कौन सी शेप पे काटना है, according to that it will be cut, right? Cutting करने का है, knife से cut कर सकता है, otherwise it can be cut with the scalpel. Scalpel पता है ना? Blade. जो OT में यूज होता है blade, कैसा दिखता है blade? ऐसा छोटा होता है। इसका हैंडल होता है, काम करता है, पेंसिल की तरह करता है ब्लेड। ब्लेड ऐसे नहीं पकड़ते, ठीक है? ब्लेड ऐसे पेंसिल की तरह पकड़ते हैं, ठीक है? So it can be removed. The skin can be removed with the knife, or it has a special knife. ऐसा नहीं जो किचन में यूज होता है, ऐसा वाला knife नहीं है। ऐसा special knife. This is known as dermatome. तो एनेस्थेशिया देने के बाद एनेस्थेशिया लोकल एनेस्थेशिया हो सकता है, रीजनल एनेस्थेशिया हो सकता है, अदरवाइज जनरल एनेस्थेशिया हो सकता है, depending on where the skin grafting is done. After anesthesia has been taken, the skin will be removed and it will placed to the where the grafting is required. ठीक है? ग्राफ्टिंग करने के बाद डालने के बाद क्या करते हैं? साइड साइड स्टिच करते हैं, अदरवाइज stitching can be done or stapling can be done. Stitching or stapling, आपने stapler देखा होगा ओटी में। ओटी के बाद लास्ट स्किन कवर कैसे करते हैं? विद द आजकल क्या करते हैं? स्टैपलर यूज होता है। स्टैपल से बंद कर सकता है साइड साइड साइड। यहाँ पे ग्राफ्टिंग हुआ है, फॉर एग्जांपल इस एरिया में ग्राफ्टिंग हुआ, साइड में सुचरिंग, अदरवाइज इट मे बी स्टेपल, ठीक है, स्टेपल और सुचरिंग। एंड द पार्ट वेयर इट इज रिमूव, जहाँ पे रिमूव किया है